Okay, sorry about that. So before we start today's discussion, we will go through like the questions from you for the last time. Okay, so I went through the feedback that you sent the last discussion, and the question that was or the point that was said by the majority of you as unclear was the one about acetazolamide using like basically the fourth SBA question, which was on idiopathic intracranial hypertension. So let me share the question with you first before we get into that. Right. So before I start explaining this one again, can somebody tell me, have you been taught about idiopathic intracranial hypertension? So have you heard this term somewhere before? Have you had a lecture on this or a class on this somewhere? Have you heard this term before? Because if not, I will have to start from the beginning. That's why. Okay, so somebody's telling me, no, you don't know. Okay, right. So I'll say like this. Now, it's the term idiopathic intracranial hypertension, I would say, is self-explanatory. So it just tells you what it is. Idiopathic means nobody knows why. Intracranial means inside the head, and hypertension is the pressure goes up. Okay, so that's the literal translation. So for no like known reason, the pressure inside the head would go up. So can this happen sometime? Yes, it can. So how would you know that the pressure inside has gone up? Basically, the patients would usually like present it headache, and sometimes they can present it visual blurring, because if like you would remember that in those who have increased intracranial pressure due to any reason, they would develop papilledema, that is swelling of the optic disc. Now, why would that happen? Why would you get papilledema or the swelling of the optic disc when there is intracranial pressure going on? What is the relationship between the optic fundus and basically the optic disc and the ventricular system? Can somebody give me a clue? What is the connection between the two? Anybody? Good job. Meninges continuing the optic nerve. Good. So along the optic nerve, your three like membranes of the meninges, the dura mater, arachnoid mater, and the pia mater, continues along with the optic nerve. And the optic nerve exits the base of the brain and continues to the back of your eye. The meningeal coverings would travel along with that. So you know that CSF flows, the cerebrospinal fluid flows inside the ventricular system as well as in subarachnoid space. So the meaning of like what I mean by when the meningeal coverings travel along with the optic nerve, it also means the subarachnoid space, the subdural space. So all these spaces also travel alongside the nerve. Okay, that is what it means. So which would also mean you would have like if there is any increase in the intracranial pressure, which would mean that the cerebrospinal fluid pressure would also go up, because the cranium is an enclosed space. The Monro-Kelly doctrine, it's an enclosed space, so pressure going up in like one of the three constituents, that is the blood, the brain matter, and the CSF. So if the pressure in one of the three would go up, it would be reflected in the other two components as well. Say like the pressure goes up due to a problem with the vascular component. There is extradural hemorrhage. Because of the extradural hemorrhage, now the intracranial pressure is going up. So that would reflect on the brain matter as well as on the CSF. Okay. So you can't see what is happening on the brain matter, but you can see what is happening in the CSF. So when the CSF pressure goes up, like there's something obstructing. So that pressure is transmitted into the optic disc as well. So you see that as a swelling of the optic disc. So this is the basis of your papilledema with any cause of raised intracranial pressure. Okay. So when you see papilledema in a patient, the concern is okay, the intracranial pressure has gone up. There can be like a problem with any of the three factors that I mentioned. It could be an increase in the brain matter, which would happen with a space occupying lesion, or sometimes even with a massive infarct. Because of the infarct, I told you, like the surrounding the brain matter undergoes swelling. So this is an increase in the brain matter, would reflect as papilledema. An increase in the vascular component, such as a hemorrhage somewhere, yes, would reflect as papilledema. Similarly, an increase in the CSF component would reflect as optic disc edema or papilledema. Okay, so it's up to you to figure out, okay, why is the optic disc swollen? Okay, so some cases, now you do the brain imaging and like everything, you cannot find a reason. Okay, there is no hemorrhage and there is no like brain matter lesions. And there are other causes of papilledema that you have to look for. So we will discuss this in one of the questions that we are doing today. So you exclude all the other like medicinal, the toxic and all the other causes also. You can't find a reason why, but still the CSF pressure is high. So this is when you call it idiopathic intracranial hypertension. Okay, so there is no obstruction to the CSF flow, no bleeding, no SOL, no toxic or metabolic causes, still the CSF pressure is high. Okay, so this is the entity called IIH or idiopathic intracranial hypertension, previously known as benign intracranial hypertension. So benign intracranial hypertension and idiopathic intracranial hypertension are the same condition. We no longer call this benign because what you mean by benign in medicine is it's something harmless. But now we know, no, IIH is not really harmless. It can be quite harmful, particularly for your vision. You can go blind. If this idiopathic intracranial hypertension is not corrected, you can go blind. Why? Optic disc edema. So if the pressure on the optic nerve continues, the optic nerve head will die. Okay, so if this remains untreated, you will go blind. So it's not really benign. So because of this, we no longer call this benign intracranial hypertension. Instead, the terminology has changed. You call that idiopathic intracranial hypertension. Okay. So the usual patient with IIH is an obese, middle-aged female. Young to middle-aged, obese females are the typical patients. Okay. And there can be risk factors like smoking. Okay, smoking is a well-known risk factor. And another way in which this is given is a patient, like a obese female who is like on treatment for acne. Because retinoids and like vitamin A, vitamin A derivatives are used in the treatment of acne, a known cause of idiopathic intracranial hypertension. Okay, they can trigger. So, advice on weight reduction. Yes, you have to do that because in the longer term, so the results are going to be better if the patient loses weight. Okay, so weight has a direct connection with IIH. Advise her to avoid passive smoking. So I told you, yes, smoking increases the risk. So you need to ask the patient to stop active as well as passive smoking. Okay. Then screen for hypothyroidism. Yes, you need to do that because again, hypothyroidism is a known association, known risk factor for developing IIH. Okay. Oral furosemide again can be given, may be given. Okay, because in like intracranial hypertension, like you might think, okay, getting rid of excess water from the body might help. So there is an experimental place for that. Yes. But remember, this is the single best response type, which means all of the responses are going to be true. The problem here is on examination. So she has bilateral papilledema as well as a central scotoma. What is meant by a central scotoma? I explained the other day, like when you have your field of vision, so in your visual field in the center, there's a blind spot. What this means is your optic nerve head is already ischemic. Okay, so the part that is taken care of by the optic nerve head, that region is already dying. That means the patient has impending visual loss. Okay, this is not just blurring of vision. In addition to blurring of vision, objectively there is a spot where the patient cannot see already, which means whatever that you are doing, you have to do as soon as possible. Okay, advise the patient on weight reduction. You can do that and see how long it takes. It's going to take months or years for that to happen. You don't have that time. Within the next few hours to 24, 48 hours, if you don't reduce the CSF pressure, the patient is going to lose vision. Okay, so even though you have to do that, that is not the most appropriate next step. Same goes for avoiding passive smoking. Okay, and same goes for screening her for hypothyroidism. It's going to take a few days for the report to come back and for you to go and correct it. That is not the immediate step. Furosemide, as I said, you can use, but the evidence is not very strong. What you do instead is acetazolamide. So acetazolamide you have learned as a carbonic anhydrase inhibitor. Okay, so it's a carbonic anhydrase inhibitor. So how it works in reducing CSF production by the choroid plexus is theoretical, not exactly known. However, I found this very good diagram in one of the papers. Okay, so I will send you the link to that and I want you to go through that leisurely. Okay, it has a very good caption, which it's a figure in one of the articles on ResearchGate, and it gives a nice caption which explains everything. So I want you to go through that. That will explain things. So this is the link. Okay. Right. So at the moment, I don't see 1/3 of the patchy. I just only noticed. I assume that is because of the power cut. I will excuse for today, but mind you, I am also coming back to the faculty just to do this class. So I hope it will improve the next time. Okay. Yeah. So we'll go on to the today's paper. Right. So the first question, a 40-year-old male patient presents with shortness of breath. He had central chest pain 3 to 4 days ago, but this settled after about 6 hours and he didn't seek further treatment. You suspect the previous episode of chest pain is likely to be ischemic. Which of the following cardiac biomarkers are likely to be elevated in this patient? Okay, so this is about cardiac biomarkers and how long do they persist after going up after an acute MI, because this is 3 to 4 days after the onset of the chest pain. Okay, the first one, myoglobin, is that true or false? Answers, myoglobin, is that true or false? Good, it's false. Can somebody tell me how long it persists after an MI? Myoglobin, how long? Yeah, it's basically about 1 day, less than 1 day or less. Okay, so it's less than 24 hours. It's actually only a few hours that it would persist. So it's only a very short time. So it will not persist. Okay. And then the second one, CKMB, creatine kinase MB, true or false? Okay, so for that one, there are mixed answers. There are trues as well as false. This one is again false because, yeah, I was looking for a figure to show you. Yeah, the reason is CKMB, now I have given you here as 3 to 4 days. CKMB levels usually come down to normal within about 2.5 days. Okay, within about 60 hours, 40 to 60 hours, your CKMB levels would come back to normal. So CKMB is again false. Okay, right. And the next one is troponin T, trop T, true or false? Good, it's true. Remember, troponin T and troponin I would both last about 7 days after an MI. Okay, roughly about 7 days after an MI, it's going to be highest during the first 2 days, but after that, still it's going to persist at detectable levels for up to 7 days. Both trop T and trop I. Then why do you do troponin I nowadays instead of troponin T? If both are going to remain elevated, why would you do troponin I and not troponin T? Because troponin I is more specific. That's why it's more specific. Yes, exactly. It's more cardioselective. That's why. Okay. So which means our fourth answer is also correct. So troponin and troponin I are both correct. The lactate dehydrogen is LDH, true or false? Again, there are a bit of mixed answers, but majority of you all are correct. Okay. It's again true. Okay, LDH is one of the longest detectable substances after the MI. However, the levels are not very high, like they are modest levels, but it's like present for a long time. Goes up slow, goes down slow. Okay, right. So again, I'm going to send you a link. Have a look at this graph. I want you to follow these links. Look at the pictures, or the graphs or whatever that I send. Finish it within today because you are not going to go and do this again. Okay. So moving on to the next one. If you have any questions, you are welcome to ask. Okay. Next one, a 25-year-old male is known to have, noted to have papilledema. Which of the following is a possible causes? Now, I have spoken to you about papilledema a little bit. I don't think I need to explain more about what you are looking at when you're looking at papilledema. Now, the question is, what are the causes? First one, ALL, or acute lymphoblastic leukemia, true or false? Okay, anyone else who answered? Okay, I would take it that this is a little bit difficult for you. So given having looked at the answers and the rate at which you're answering, I would say, okay, maybe it's a bit too difficult for you. So the answer is true. ALL, or acute lymphoblastic leukemia, is a known cause of papilledema. Okay. The reason is ALL can affect your central nervous system. Okay, it can affect your central nervous system. There are many reasons why it's true. Okay. Oh, there are only 4 answers. I put 5 here. Let me check. Okay, I'm sorry about that. I don't know how that happened. It was supposed to have 5 answers. This is the 5th one. Okay. Right, that is the 5th one. So in acute lymphoblastic leukemia, there are due to many reasons it can cause papilledema, and one of the reasons is now this ALL can infiltrate your central nervous system. Okay, whereby you will have a lot of cells in the CSF. So these cells can go and obstruct the CSF flow. So due to this also you can develop papilledema. Okay, so that is one of the commonest causes. But there are other unknown mechanisms by which ALL can produce papilledema. Okay, so it's a rather uncommon cause. So I told you in the best of the true or false type, be careful when answering all 5 responses because there are difficult ones. Okay, so ALL is true. Next one, cerebral abscess. Can that cause papilledema? Good. Yes, of course. Cerebral abscess is a space occupying lesion. So that would increase the brain matter space, which would mean the pressure would go up. The intracranial pressure would go up. So cerebral abscess, the answer is true. Cocaine poisoning. Okay, not bad. Some of you got it. The answer is again true. Cocaine poisoning can be like cocaine is one of the worst substances that you can ever poison. So be careful if you think about doing drugs. Do anything, I would say, except for cocaine and LSD. Those are 2 of the worst type of drugs that you can do. Okay. I would say don't do any drugs, but if you ever think of experimenting, I would say never experiment cocaine. Cocaine is a very dangerous drug, extremely dangerous. It can have a lot of vascular side effects. One of the things that it does is it sends your arteries into a severe spasm, severe vasospasm. So cocaine poisoning can present with acute myocardial infarction. So we see this not uncommonly. Not uncommonly. So we get patients with young myocardial infarctions, young MIs. We ask them have you taken cocaine? Almost always they say no, as is the custom because taking drugs is considered very stigmatizing. Patients would often deny taking the drugs, but then you screen them for everything under the sun, nothing comes back positive. Like they don't have diabetes, no dyslipidemia, no family history, no hypertension, so nothing is there, no risk factors. And also, given that these are young patients, you would think about transferring them to a unit with at least rescue PCI. And then you get a call from the senior registrar in the cardiology telling your ear off because they did the angio, which is perfectly normal. And because the angio is normal, they went back in the history and asked from the patient, and the patient admitted to taking cocaine. Okay. The reason why they get so upset, the cardiology team, is because this was an unnecessary angiogram. The reason is, as I said, cocaine-induced myocardial infarctions happen due to arteriospasm. The artery goes into a spasm and it is otherwise normal. So it's not an obstruction. It's not an obstruction caused by an atheromatous plaque. So by doing a PCI, you are not going to achieve anything because this is a transient spasm of the blood vessel, which is going to go once the cocaine is out of the system. So it's completely reversible. Okay, so given there's no atheromatous plaque, even if you do the PCI, there's nothing for you to stent. Okay, so it's an unnecessary PCI, but like in practice, you will see it's not uncommon for patients to like come, young patients in their 30s, 20s to come with acute like ST elevation MIs. Mind you, these are usually ST elevation type of myocardial infarction. So the cardiac damage is already done. Okay, and like you do the angiogram, it's going to come back perfectly normal, squeaky clear. Okay, so the same thing can happen in your brain as well. So severe vasospasms leading the patient to strokes. A complete stroke, they can come with like complete hemiparesis, young patients. Okay, but the problem is the stroke is not reversible. The vasospasm is reversible, but by the time it reverses, the damage is already done. Okay. Then how can they have papilledema? Two possibilities that I can think about. One is if they have a massive stroke. I said with a massive stroke, they can develop increased intracranial pressure and therefore papilledema. The other reason is because now if all over, like if the majority of your blood vessels all over the body go into a spasm, what will happen is the total peripheral resistance would go up. Because of the vasospasm, I talked to you about this the other day also, blood pressure equals cardiac output into total peripheral resistance. So if the total peripheral resistance goes up, your blood pressure will go up. Okay, so sudden severe increase in blood pressure is known as malignant hypertension. Sudden severe increase in blood pressure, like severe increase in blood pressure causing organ damage, you call that malignant hypertension. So malignant hypertension is a known cause of papilledema. Okay, which would mean answer E is also correct. So cocaine poisoning can give rise to papilledema in these two ways. It's either malignant hypertension with hypertensive encephalopathy or a massive stroke. Okay, right. So C would be correct and E would also be correct. Next one, D, hypocalcemia. Is that true or false? Okay, those who guessed, I would say majority of you guessed it correct. That is true. When something as absurd as this is given, usually it is true. Okay, but don't take my word for that. Don't do it all the time. But usually, like it completely, utterly does not make any sense. Like, how would hypocalcemia cause like papilledema? Usually, if you like feel like that, usually they are correct. Okay, again, the exact reason is not known why hypocalcemia causes papilledema, but it is a recognized cause. There are certain medications also which can cause papilledema. One that I can remember is nalidixic acid. Nalidixic acid, I don't know whether you have ever heard about that. That's an antibiotic that was used in the treatment of urinary tract infections. Okay, called nalidixic acid or N-acid. So this was a known cause of like papilledema. Okay, so there are other causes. So what the lateral learning from this is that you are going to find out the other causes for papilledema. Okay, so can't it be due to cerebral edema? So are you asking about cocaine poisoning, Mangi? Like cocaine poisoning causing cerebral edema and then like papilledema, or is it about hypocalcemia causing papilledema? Yeah, hypocalcemia. Yes, like hypocalcemia can lead to cerebral edema as well, leading to papilledema, but independent of cerebral edema, it can cause papilledema. This is why I say like the exact mechanism is not known. Okay, so yes, it can lead to cerebral edema as well, which can in turn lead to papilledema. At the end of the day, hypocalcemia, yes, it causes papilledema. Okay, so you need to excuse me a minute. I need to take an okay, sorry about that. So we'll move on. The next one is, which of the following is a causes of hypokalemia? The first answer being diabetic ketoacidosis. True or false? Okay. I don't know why most of you thought that that was correct. Yeah, now I'm getting a bit few falses. Good. This is false. In diabetic ketoacidosis, what you usually get is the hyperkalemia, not a hypokalemia. Okay. The reason being, DKA is a state of relative insulin deficiency. Okay. Relative insulin deficiency. So we call that starvation in the midst of plenty, because the cells are starving. The cells don't have anything to eat, but your blood is full of sugar. Blood sugar levels are very high, but your cells are starving. Why? Because there is not enough insulin. Insulin is the one that mediates glucose entry into the cells. So even though there is a lot of glucose, the cells cannot take this up. Okay. In addition to the effect on glucose, what else it does is it also increases the intake of potassium into the cells. Okay, so the potassium transport. Now, potassium, you would remember, is an ion that is high intracellularly and low extracellularly comparatively, because intracellular potassium levels are like in the range of 130 to 140 millimoles per liter. But extracellular, the levels are between 3 to 5 millimoles per liter, 3.5 to 5.5. Okay, so extracellular, the potassium levels are usually low. So what insulin does is help the potassium to go into the cell. So when there is no insulin, relative lack of insulin, potassium will collect outside of the cells. So potassium cannot be internalized if there is no insulin. Okay, so which means what you measure as serum potassium is potassium that is outside of the cell. So outside the cells, the potassium levels will go up. Okay, so I'm not asking here about the total body potassium level. What I'm asking is hypokalemia. Hypokalemia means for low potassium in the blood. Emia. So it's low potassium, measured low potassium levels in the blood. Okay, so what happens in decay is increased potassium outside of the cells. Okay, I hope you understood that. So let's see. Okay, so you have the cells and then you have the blood vessels. Okay, so potassium is usually high within the cells and low outside of the cells. So when there is insulin, insulin helps potassium to move from blood into the cell. This is what insulin does. So if you don't have insulin, potassium will collect in the bloodstream. In the blood side of the things, the potassium will collect because there's no insulin to internalize the potassium. Okay, so because of that, the measured potassium level is high. Okay, yeah. So I see the comments that you are sending. So you are asking like can the diuresis, the osmotic diuresis, can that be present in like severe decay, can that precipitate hypokalemia? Yes, true. But this is not the common picture that we see. So when we ask like, okay, decay, like hypokalemia seen in decay, what we are asking is the common presentation. Okay. Severe osmotic diuresis in severe decay, yes, it can precipitate low potassium levels. But generally speaking, when patients come in with decay, but they have this high potassium levels. But we specifically say, don't treat the high potassium level. Okay, don't treat the high potassium level. The reason is their total body potassium levels are usually low. Total body potassium is if you incinerate the person, if you like burn the patient up, put them in an incinerator, burn them up, measure their total body potassium. Their total body potassium level is actually low because they have potassium in the wrong place. It's extracellular. When you want it to be intracellular, it's extracellular. So there is potassium in the wrong place, which is not great. Okay. So because of that, so another question, can metabolic acidosis in decay precipitate hyperkalemia by sodium, potassium, hydrogen, potassium ATPase mechanism? No, that is not the mechanism. The mechanism here is, it's the hydrogen, potassium ATPase, but it is due to the insulin. So insulin is the driver of this ion channel. Okay, so without insulin, what you get is a relative hyperkalemia. Okay, right. So once you treat them with insulin, so what you treat is, now when you treat a patient with diabetic ketoacidosis, you do not target the hypokalemia itself. Because as I said, their total body potassium levels are actually low. So once you start treating them with hydration and insulin infusions to correct the sugar levels, once the sugar and the ketoacidosis, once that correct, their potassium actually starts dropping. So after you initiate the treatment, so that is why in the decay treatment regimes, they say after the first hour, start them on potassium infusions as well. So after the first 1 liter of fluid replacement, you start them on potassium replacement as well. This is the reason why. Okay, because once you provide them with insulin, these pumps, everything, they normalize. So once they normalize, you are in trouble because as I told you, the total body potassium levels are actually low in there. because of the osmotic diuresis. With the diuresis, they have been losing sodium and potassium in the urine. Okay, so which is not great. So now once you have started the insulin, you have corrected that, and because of that, the actual measured potassium levels start dropping, at which point you need to start correcting. Okay, I hope that that is clear. Right, if you still didn't understand, you can ask me. Right? And the next one is excessive vomiting. Excessive vomiting, is that true or false as a cause of hypokalemia? Good, it's true. You would remember, like if you are vomiting excessively, you would be losing a lot of acid, H+. Okay, and if you think about how is H+ secreted into the into the stomach, you will remember the hydrogen potassium exchange. Okay, sorry, the hydrogen potassium co-transporter. So when there is loss of hydrogen, the body will be trying to put out more acid into the gastric lumen, which means more potassium will come out again. It's going to be lost because you keep on vomiting. Okay, so which means with the upper GI losses as well as with lower GI losses. So vomiting is a cause for hypokalemia as well as diarrhea. Both vomiting and diarrhea will lead to hypokalemia. And vomiting, severe vomiting leads to hypokalemia in another way because it can affect your renal handling of potassium as well, but you don't need to know that far. That's more at like postgraduate level. But the bottom line is, yes, excessive vomiting causes hypokalemia. That is true. Furosemide? Come on, that is the easiest one. Yes, that is the easiest one out of the five. So that is true because furosemide, you know, is a very potent loop diuretic. Okay, sodium potassium 2 chloride transporter blocker. So it's a like a very potent loop diuretic which causes potassium losing. So patients on high doses of furosemide, for other reasons, you might want to replace their potassium. Okay, because they can develop dangerous hypokalemia. Then the next one, metabolic alkalosis. Okay, good. Metabolic alkalosis is also true. Again, it is to do with the potassium hydrogen channel. Okay. Next one, type 4 renal tubular acidosis. Type 4 RTA. Okay, I would say this is perhaps where you should have been a bit careful, bit cautious. Because renal tubular acidosis, you know, like there are basically 3 types. Even though we say type 1, type 2, we don't really talk about a type 3, it's type 4. So type 1, type 2, and type 4 are the 3 common types. Sorry about that. Yeah, so type 1 and type 2, definitely yes. So type 1 and type 2 are what we call distal and proximal. Okay, where you lose a lot of electrolytes. So hypokalemia is a known feature in type 1 and type 2. Type 4 actually causes hyperkalemia. Okay, type 4 renal tubular acidosis is a very special type of renal tubular acidosis that we see in patients with diabetes. Those with long-standing diabetes, they come with like renal impairment, like raised creatinine. However, not like very high. So like if your normal serum creatinine range is say 60 to 120, they come with like serum creatinine values of about like 140, 150, like not very high. However, they have hyperkalemia. So never attribute that to the CKD. Because for chronic renal failure, chronic kidney disease to cause hyperkalemia, you have to be in stage 4 or stage 5. So advanced CKD, yes, will cause hyperkalemia, but this is like stage 3, stage 2, stage 3. If you go by the EGFR, like if you calculate the EGFR for these patients, they will be about like stage 3 at best. It's not supposed to cause hyperkalemia. So this is type 4 renal tubular acidosis. Okay, so it causes a hyperkalemia, not a hypo. So did you understand? So these are patients with diabetes with mild renal impairment who come with hyperkalemia. Okay, the treatment is different. You treat them with something called, anybody knows what it is? The treatment? Those who got the answer correct? Okay, so the treatment is with a mineralocorticoid replacement. You treat them with mineralocorticoids. That's the treatment. Okay? Yeah. So next question. So the last true and false type. Which of the following is our extraintestinal manifestations of inflammatory bowel disease? Extraintestinal manifestations. So you know, IBD or inflammatory bowel disease can affect a lot of parts of your body except for your bowels. It will like definitely affect your bowels, but in addition, it can affect a lot of other parts of the body as well. So these are what are known as extraintestinal manifestations. Scleritis, true or false? Lamai, this is false. This is why I told you be very careful if the answer seems too easy. It doesn't cause scleritis. What it causes is anterior uveitis. Uveitis and scleritis are two different things. So scleritis you get with rheumatoid arthritis, but not with IBD related. Okay, so inflammatory bowel disease is ulcerative colitis and Crohn's, but you get this uveitis. You can get anterior uveitis, sometimes in severe cases even pan uveitis. That is the whole of the choroidal, so that area being involved. Not scleritis. This is false. Okay, so anterior uveitis is basically iritis, the anterior part of the cornea. So the answer is false. Next one, sacroiliitis. Good. Yes, it is true. Sacroiliitis, because inflammatory bowel disease, both Crohn's and ulcerative colitis, can be associated with a type of inflammatory arthritis that we call spondyloarthritis. Okay, a type of inflammatory arthritis called spondyloarthritis, which means arthritis including the spine. Okay, so the spondyloarthritis, one of the typical features is sacroiliitis. Okay, yes, so there is a question, can it cause episcleritis? I honestly don't know. I'll have to find out. So episcleritis is again a feature that you get in rheumatoid arthritis, but whether you can get it in IBD, I'm not sure, but I will find out. Okay. Next one, sclerosing cholangitis. True or false? Good. A lot of you answered. The answer is true. Sclerosing cholangitis is true. Deep vein thrombosis, DVT. Good. That's again true. Again, the exact reason we don't know why it causes DVT, but IBD is known to increase the risk of deep vein thrombosis, particularly during acute flares of the inflammatory disease. They can develop DVT. Okay, probably because it induces a sort of a generalized inflammatory response. All your blood vessels are also inflamed, probably because of that. Exact reason we don't know. It's considered a prothrombotic state. Okay, so yes, DVT risk goes up. Pyoderma gangrenosum. Good. That is also true. So now look at this question. Now remember what I told you about being careful in answering all 5 responses. Okay. So if you look at this one, sclerosing cholangitis and pyoderma gangrenosum, I would say are pretty easy. Anybody would know, like the majority of you would know about sclerosing cholangitis and pyoderma gangrenosum. If you have read a little about IBD, you would know because these are like common manifestations. Sacroiliitis, again, if you know that it causes spondyloarthritis, you can work out. So second, as the sort of second difficult step, I would say sacroiliitis, again, you would know. But deep vein thrombosis and scleritis are difficult ones, relatively. Like compared to the other ones, these 2 responses are the difficult ones, particularly the one about scleritis. You would know, yes, it affects the eye, but does it affect the sclera itself? You might not know. So scleritis is the most difficult one. DVT is the one before that. Okay, so this is why I say be careful when answering all 5. So if you answered 4, like excluding scleritis, most of you knew the others. So if you just left it at 4, you would have gotten 4 out of 5. But if you went ahead and like got too greedy, answered scleritis, also got that wrong, you end up with 3 out of 5. Because you get 1 negative mark. Okay, so this is why I say be very careful when answering all 5 responses. Okay, yeah, so we'll move on to the single best response type. So a 48-year-old male smoker presents with gradually worsening SOB for 6 months on the chest X-ray. Presence of which of the following features would suggest the cause of SOB to be pulmonary hypertension? Okay, so pulmonary hypertension, what is the feature that would suggest that? A, B, C, D, or E. It's okay if your answer is wrong. I don't mind. Just send in the answer that you have put because that gives me an assessment of your way of thought. I can explain things easier. Okay, so I would say out of those who sent in the answers, the majority of you got it correct. But there was a bit of other answers as well, mainly A and D. The correct answer is answer B. It is peripheral pruning of the vessels. So I will explain what is this peripheral pruning. But the other two answers are double contour sign and upper lobe blood diversion. Okay, so I would recall here failure. Okay, so we go to a whiteboard and see why that happens. Okay, so in the chest X-ray, now you have the lung shadow like this. So what you mean by upper lobe blood diversion is on the X-ray, you will see like very prominent blood vessel markings on the upper lobes compared to the lower lobes. So this happens in heart failure because in heart failure you get pulmonary edema. Pulmonary edema means in the lower parts of the lung you will get collection of fluid. Because fluid is gravity dependent, fluid is heavy. When you are standing up, fluid will accumulate in the lower parts. Whereas the lower part of the lung is better perfused. That is the physiological distribution. The upper part of the lung has better aeration. Lower part of the lung has better perfusion. However, now because of the gravity, fluid is accumulating in the lower part of the lung, which means the upper part of the lung is the better place for the blood to go if they want gas. If they want oxygenation, the blood has to be diverted to the upper part of the lung, which are better aerated because the lower parts are not getting enough air because fluid is accumulated. This is what you see in upper lobe blood diversion. So the blood vessels to the upper part of the lung are preferentially dilated to make sure that the oxygenation happens. Okay, so this is a feature that you see in heart failure. This is actually the earliest radiological feature that you see in heart failure. Okay, so what do you mean by peripheral pruning of blood vessels? Pruning is, okay, so that is pruning. So you have a tree, you go and cut the distal most parts to make it into a shape. So this is the literal meaning of pruning. So what happens in pulmonary hypertension? Okay, that means now in the pulmonary veins, mind you. So the pulmonary arteries, not the pulmonary veins. In the pulmonary arteries, the pressure goes up. The pulmonary arterial blood pressure goes up. When that goes up, to withstand this blood pressure, so the pressure is going up, and this is actually in the pulmonary arterial side. So to withstand this pressure at the capillary level and the arterial level, and the capillary level, the vessel thickness will go up. The vessel thickness will go up to withstand the increase in the pressure. Okay, so with the thickness of the vessel going up, this would mean there is going to be luminal narrowing. That is the internal lumen, the lumen of the blood vessel is going to narrow because the vessel thickness goes up. The thickness is not growing outward, it's growing inwards. So the lumen of the blood vessel is going to narrow. Okay, so pulmonary arterial hypertension, there is luminal narrowing of the blood vessel because the blood vessels have to, you have two options. You either increase the thickness and withstand the pressure, or you burst. If you burst, you die. Okay, so we are very adaptable creatures. We don't want to die. So instead, we increase the thickness of the vessel wall to withstand the pressure. When the thickness goes up, the intraluminal diameter goes down. So because of that, towards the peripheries, the blood supply. So if you look at the vessel shadows, the blood vessel shadows, the shadows are going to disappear towards the latter part of the lung. So you will see blood vessels traveling towards the periphery from the hilum, but they will like disappear in the last 1/3 of the lung field. So you call this peripheral pruning, and that is an adaptation to the increased pulmonary pressures, pulmonary arterial pressures. Okay, so in that case, peripheral pruning is true. Right. Next one. And the other one that you had given was the double contour sign. So double contour sign is something that you see. Does anybody know where? When do you get double contour sign? Isru, you are close, but not there. Yes, Umangi. Good. Mitral stenosis. Not mitral regurgitation. You get that in mitral stenosis. Okay. So if you are again lateral learners, you are going to go ahead and read about, okay, then where would you get the other sign? So what is double contour sign? Where do you get double contour sign? What is curly C line? What is the egg on the side appearance? Okay. So what are the causes of these? If you are like active learners, you are going to go and find these. Okay. Right. The next one. A 50-year-old female with long-standing diabetes presents with acute worsening of shortness of breath. She has a history of exertional SOB, and now she has orthopnea but no chest pain or tightness. On examination, she is edematous, has an elevated JVP, and the cardiac apex is shifted. Okay, so she has enlarged heart. Lung bases have fine crepitation. So basically, she is a patient who is in congestive cardiac failure. Okay, and now coming with like acute worsening due to LVF. Pulse rate 90, blood pressure is 110 by 80. Which of the following is incorrect regarding her management? Okay, send me the answers, please. We'll see how you have done. Just send me the one that you have put. It doesn't matter whether the answer is correct or wrong. Okay, so for this one, I have A's, B's as well as C's. The commonest being C, next common is A, and the next common is B. Okay. The answer here is C. Okay, the correct answer is C. What we are asking is which of the following is incorrect regarding her management. Okay. So the diagnosis here is acute heart failure. So there are no two questions about that. The diagnosis is acute heart failure. So what are you going to do to relieve acute heart failure? So you need to know two things here to answer this question. How do you manage acute heart failure? So like there are things that you can work out. Okay, that is one thing that you need to know. There are certain treatments that you can work out and see, okay, whether they will work or not. And the other one is I'm asking about the survival benefit, mortality benefit, and all this. So these things you should know. I told you, I think, I can't remember that I told you or not. So the survival benefit things, they come from trial evidence. So you can't really work them out all the time. Sometimes you can work it out, sometimes you can't. Okay. So the answer like B, ACE inhibitors have known survival benefit. You can't work it out. If you can, that's fine, but usually you can't. So the answer is true. ACE inhibitors do confer a survival benefit. So in heart failure, like in the acute management as well as long-term management, yes, it does confer a survival benefit. So that's true. Acute coronary event should be considered as a possible cause for the current presentation. Again, true. Even though she has no chest pain, this is a patient with long-standing diabetes, coming with acute worsening of like long-standing heart failure. Of course, you need to think about like what led to this acute decompensation. It could be an acute myocardial infarction. So you have to always look for this. So E is also correct. So those two are not the correct answers. So A, B, or C. She will benefit from a slowly titrated IV GTN infusion. Intravenous furosemide is beneficial over oral furosemide in the acute situation. Beta blockers have to be started immediately for the mortality benefit it confers. Okay, so we'll think about B first because that is the least common out of the three answers. IV furosemide is beneficial over oral furosemide in the acute situation. The answer is yes. Okay, if you just look at furosemide oral versus IV, one is not superior to the other. Okay, both have similar efficacy. But in heart failure, that is different. The reason is this is a congestive heart failure. I have given that the patient is edematous. She has an elevated JP. So there is right heart failure as well. So if the right heart is failing, the edema that you see from the outside happens on the inside as well. So your gut wall, for example, is edematous. So if your gut wall is edematous, is the absorption going to be very successful? No. So any medication that you give orally, you cannot really talk about like the absorption is going to be erroneous. Because why? When the gut wall is edematous, absorption takes for medication to travel into the blood vessels from the gut lumen into the blood vessel to the bloodstream, it has to travel a longer way because the gut wall is thick with edema. Okay, which means the absorption is going to be erroneous. So yes, IV furosemide during the acute stage, because IV, once it is given, you know that it's in the system. Once it is given, it's given. So during acute heart failure, this answer is true. IV furosemide is beneficial over oral furosemide. Okay, right. So is it A or C? Now I would say those who chose A probably thought that IV GTN has no place because the blood pressure is 110/80. We talk about intravenous GTN infusions when the patient has hypertension. But no, it has an application here as well. Because GTN, if you remember, in addition to being a vasodilator, it is a very potent venodilator. Okay, it dilates your venous system as well. Okay, the idea here is by dilating the venous system, it will reduce the preload on the heart. Okay, so the heart is failing. It is like trying very difficult to pump. So if you reduce the preload, that will try to reduce the burden on the heart as well. Okay, so that is the idea. So by giving IV GTN, you are actually improving the cardiac function in those who have acute heart failure. So in acute pulmonary edema, acute heart failure, there is a place for IV GTN. Okay, so that's why I have said slowly titrating the GTN infusion because the patient's blood pressure is like 110/80. So as long as the systolic blood pressure is above 90 millimeters mercury, you can still give IV GTN. So you start at a low dose and then slowly titrate. This actually relieves the patient's shortness of breath very quickly. Okay, it's very effective. So that does have a place. So what is wrong here is beta blockers have to be started immediately for the mortality benefit it confers. Okay, do beta blockers have a mortality benefit in heart failure? The answer is yes. In the long-term management of patients who have heart failure, beta blockers are a must. The patients have to be on beta blockers. However, when we start it, we say wait until the patient is euvolemic, which means the edema has settled and the patient is like relatively stable. Wait until that time. One of the reasons is now in acute heart failure. Now think about beta blockers. Beta blockers are negatively inotropic, negatively chronotropic. So these patients have already the ventricular function is low. So on top of that, you go and give a negative inotrope. That's not the best. So you wait until the patient is stable. So you wait until the acute heart failure is managed, and then you start the patients on beta blockers. Okay. So beta blockers do confer a very significant mortality benefit, but you don't start that during the acute period. That is why it is incorrect. Okay, so if you didn't understand again, you can ask. The answer is C. Right. The next question, a previously healthy male presents to the A&E with a history of palpitations on and off for 6 hours. The last episode started about 15 minutes ago and is still continuing. He complains of feeling lightheaded and he's obviously dyspneic. His peripheral pulse is 180 per minute and the blood pressure is 85 by 50 millimeters mercury. ECG shows a monomorphic broad complex tachycardia. Which of the following is the best initial step in the management? Okay, from Isuru regarding the previous question, there is a question about acute heart failure. So should we wait till the acute heart failure is managed to start ACE inhibitors or ARBs, aldosterone antagonists and empagliflozin as well? No, not really. As I said, as long as the patient's blood pressure is stable, you can start on this. Okay, so blood pressure stable in the sense systolic blood pressure above 90, we generally start ACE inhibitors, ARBs during the acute stage itself. Same goes for aldosterone antagonists and empagliflozin as well. Okay. Right, for this question, what is the answer? I'm asking the best initial step in the management. Good. Everybody who answered got the answer correct. Okay, everybody who sent in the answer. I don't know about the rest of you. So the answer here is direct current cardioversion. The answer is E. Okay. The reason is now, if you talk about can you give IV procainamide? Maybe yes, because what we are talking about here is ventricular tachycardia. It's a VT. Monomorphic broad complex tachycardia. Most likely this is a VT. Can you give sotalol? Can you give amiodarone, IV verapamil? Almost all these answers are true. But the problem here is this is a patient who is hemodynamically unstable. How do you know whether, okay, tell me, how would you know whether a patient is hemodynamically unstable? What are the features that you look for? How do you know whether a patient is hemodynamically unstable? Good is if the patient has chest pain, yes. Anything else? Features of shock, low BP, yes. Exactly speaking, Kalana, good. Systolic blood pressure less than 90. So when you say low BP, you have to define that. So systolic blood pressure less than 90 millimeters mercury. Agreed. Syncope. Okay, syncope in the sense I would say CNS features. Features of CNS depression, including syncope or pre-syncope. So this patient hasn't had syncope. He's just saying that he feels dizzy. Okay. Right. High pulse rate? No, not high pulse rate. There is one more. One more, chest pain. Systolic blood pressure less than, what do you say? Less than 90. Yes, good preemption. It's heart failure features. Patient complaining of complaining of shortness of breath. Okay, sorry, I was really distracted because I was trying to find something. I can't find it now. Okay, because there used to be something called the BTS or the British Thoracic Society guideline on the management of arrhythmias. I can't find that online anymore. That was a beautiful guide. It used to be a really beautiful guide because it gave you like a very comprehensive flow chart into like how are you going to manage arrhythmia when they're present. So basically, if it is a tachyarrhythmia, doesn't matter what the tachyarrhythmia is, if the patient has any of the 4 features that we talked about, any of the 4 features that tells you that the patient is hemodynamically unstable. Systolic blood pressure less than 90, the patient is feeling dizzy, like CNS features of CNS depression, like syncope, presyncope, all these features. Patient has ischemic type chest pain, or the patient has shortness of breath indicating heart failure. Any one of these 4 features, the patient is hemodynamically unstable, which means the management is electrical. Because you can cardiovert a patient chemically or electrically. So there is something called chemical cardioversion, something called electrical cardioversion. Chemical cardioversion is all good, but it takes time. When the patient is hemodynamically unstable, you don't have time for chemical cardioversion. You don't have time for trial and error. You have to go for electrical cardioversion. Okay, so that is why the answer here is E. Okay, so again, active learning, you are going to go and find out the management of tachyarrhythmia. So emergency management of tachyarrhythmias is something that you need to know. Okay, including the drug doses. So you are going to go and find out. Right, the last question. So this is an interesting question about prolonged hypoglycemia. What is the cause? Send in your answers. So even 24 hours after admission, the patient is still hypoglycemic. What is the cause? Okay, so I have as answers here B, D, and E. You know, metformin and sitagliptin, or like at least metformin almost never causes hypoglycemia. You should never assume that metformin is the cause for hypoglycemia. It will reduce the sugar levels to normal, but it does not overcorrect. Okay, so metformin is definitely not the answer. Sitagliptin again is very rare to cause hypoglycemia, and again not prolonged hypoglycemia. So you correct it and the patient is fine. The question here is now, even after now, one thing is the patient presented with a blood sugar level of 35 milligrams per deciliter. So this is severe hypoglycemia. 35 milligrams per deciliter is severe hypoglycemia. Okay, so this severe hypoglycemia, what are the possibilities? So the answers you are left with are B, D, and E. Glibenclamide, poor food intake, insulinoma. Okay. All these 3 years, they can cause hypoglycemia. But about answer D, poor food intake, I would say very unlikely that it would drop the sugar level below 35. Okay, it's very unlikely. And like the patient is now in the hospital, like he has been given like the sugars and most likely he's been started on other feeding as well because he's in the hospital now. Okay, and the oral hypoglycemic agents are stopped, but still he's hypoglycemic. poor food intake is very unlikely to cause these low levels of sugar. If it is possible, don't think about doing an internship because you will go for like 24 to 36 hours without food totally, and you will still be up and functioning. Okay, you can see when you do your internship and you will remember me at that time. You will not be hypoglycemic, definitely not to these levels. Okay, so the answer, is it insulinoma or glibenclamide? Yes, insulinoma is definitely a consideration here. Definitely. However, what is the best answer here? The patient is on glibenclamide. He's 75 years old. So this is why we say in the geriatric population, like above 65 years of age, be very careful when you're prescribing glibenclamide. Glibenclamide is a sulfonylurea which has a very long half-life. Okay, the half-life is like 24 to 36 hours. But in the geriatric population, like in the elderly, the way that drugs metabolizes is not the same. So you can have prolonged hypoglycemia, sometimes even up to 72 hours after ingestion, you can have hypoglycemia after stopping. Okay, so even after stopping, he has continuous hypoglycemia. So this is the best answer. So glibenclamide is the most likely answer, not insulinoma. Okay. Yeah. So any questions? So if no questions, can you send in please the muddiest point, the one that you didn't understand well, and the clearest point. Once you have done that, you can leave.